Hello, I'm Karen Howard, the Director of Policy and Advocacy at Mental Health America, and before we begin today's program, I wanted to share a few items. First off, thank you for joining today's National Policy Institute, Addressing Youth Mental Health in Schools. Mental Health America is very proud of the work and advocacy of today's speakers. For some, the emphasis on better preparing school districts to meet student mental health needs is the culmination of their life's work. And for others, they are just beginning their journey, such as MHA School Advisory Board members and youth activists Angela Wallace of Massachusetts, a student, and Ben Ballman of Maryland. It's a pleasure to welcome you to our meeting, and we appreciate all of those who make this event possible. I have two special thank yous today. The first is to our generous sponsor, Kaiser Permanente, whose staff and leadership will make remarks opening and closing today's program. The second thank you is to MHA's President and CEO, Paul Gianfrido, who has shown tremendous grace under fire and provided steady, strong, and compassionate leadership to advance MHA's mission and empower its staff. We greatly appreciate your commitment and will miss Paul as we welcome a new CEO at the end of this month. To join this conversation on social media, please follow us on Facebook, Twitter, Instagram, LinkedIn, and use hashtags MHA Policy 2021, Youth Mental Health, and our philosophy before Stage 4. I will now turn the program over to Don Mordecai, National Leader for Mental Health and Wellness at Kaiser Permanente. He's a well-respected visionary in the policy world who will provide some welcome remarks and discussion about KP's current programming.
Greetings. Thank you everyone for joining us today for Mental Health America's 2021 Policy Institute. While thankfully it appears that we're emerging in the United States from the immediate crisis of COVID-19, there's an obvious second crisis in the making, a mental health and substance use crisis. Even before COVID-19 had a significant impact on the social, emotional, and mental health of so many, approximately 1 in 4 youth, young adults, and adults had a mental health and/or substance use disorder. So we all know someone, love someone, work with someone, go to school with someone, are someone dealing with these conditions. And most of them start in childhood or by young adulthood. Fewer than half of people living with these conditions, even before the pandemic, got any treatment at all for them. And far fewer than half who needed it got treatment for substance use disorders. These numbers are worse for youth and for those in Black, Indigenous, and people of color communities. Finally, there's been a very significant increase in overdose deaths in the past year, over and above the record-breaking levels we were already seeing before the pandemic. So today we'll be addressing the mental health needs of youth in schools, particularly exploring how to better meet the needs of underserved youth, including those who identify as Black, Indigenous, people of color, and LGBTQ+, and women during the perinatal period. The disruption of school closures and stay-at-home orders has had a significant impact on young people in terms of isolation and loss of community. There's been the loss of significant rites of passage, including graduation ceremonies, athletic programs, and other important moments for youth and young adults. As a result, it's important that we ensure that schools have the resources to help students, teachers, and school staff cope with all the emotions and challenges that will come with re-entry to whatever our new normal together will be. As policymakers, healthcare professionals, and mental health advocates like ourselves work to support the growing mental health needs of youth in our country, I'd like to share a few Kaiser Permanente initiatives intended to support youth and adults who work with them. The first is called Resilience in School Environments, or RISE. RISE empowers schools to create safe and supportive learning environments by cultivating practices to strengthen the social and emotional health of all school employees and students. RISE was developed as part of our Thriving Schools initiative and works with schools and districts to prepare school employees to better understand and integrate social and emotional well-being into all aspects of school life. Next is Ready, Set, Rise. In collaboration with Discovery Education and Alliance for a Healthier Generation, Ready, Set, Rise offers a no-cost, on-demand series of e-learning modules that inspire transformational learning experiences. This initiative reinforces the foundational importance of human connection and empathy in schools. This program will be highlighted in today's Policy Institute, where you'll learn how your community can take advantage of these rich resources. Finally, there is findyourwords.org. In 2016, we launched a multi-year public health awareness effort to reduce stigma and normalize conversations about mental health called Find Your Words. The findyourwords.org website features information to help everyone learn how to start conversations, connects people to a resource center with helpful tools and online communities, and helps people find support for themselves and the people they care about, including children and teenagers. So before we begin, I'd like to share the 4 objectives for today's Policy Institute. We hope you'll be able to walk away with these high-level learnings and gather resources you can use to support your own communities. The first objective is to understand the prevalence and risk factors associated with child and adolescent mental health and the new trends that have emerged during the pandemic. The second objective is to learn about the principles that Mental Health America found integral to equipping school settings to prevent emotional disturbances and mental health conditions in students. Objective 3 is to recognize youth who have catalyzed school district and statewide level changes through their advocacy. And finally, we hope you'll learn about ways schools can finance mental health services through Medicaid and other innovative financing solutions. I'll now turn it back to our hosts at Mental Health America, who will introduce our first speaker. Again, thank you for joining us today.
Very well said, Don. So I'm just so excited to introduce you to Paul Gianfrido. And Paul takes some time to outline what we saw in MHA screenings, which is our largest online program. We will hear from Paul about what's happening with young people, how young people increased the numbers of screenings they were taking, and some other trends. Take it away, Paul.
Thank you, Karen. And thank you, everybody, for attending this Policy Institute this year. Hopefully next time round, we'll be able to do this all in person. But doing this virtually has given us an opportunity to involve many more people in this Policy Institute and get the word out as well to many more people than we were ever able to do before. So this is as important as it can possibly be this year too, because as we are returning to normal, we need to recognize that the pandemic has taken an immense toll on our nation's young people. At Mental Health America, we have seen an explosion in the number of 11 to 17-year-olds who have screened for mental health problems since the start of the pandemic. Now, keep in mind that young people were always more deeply affected by mental health issues than older generations, largely because, as we all know, mental health conditions first emerge during childhood and the young adult years. So it was no surprise that we were already seeing a lot of young people who were screening for mental health problems using Mental Health America's online screening resources. But in the last year, this number has gone up dramatically. Nearly 40% of the people who used mental health screening resources in the course of the past year identified themselves as ages 11 to 17. And another significant group was 18 to 24. But among those 11 to 17-year-olds in particular, we saw a significant percentage of them who are expressing thoughts of suicidal or self-harm ideation on more than half the days of the week. They've been telling us over the course of the past year that the pandemic has affected them deeply. And they have been communicating in that it has affected them more deeply than it has affected any other population subgroup. And when we look at populations of people who have historically been minoritized, Blacks, Indigenous, people of color, LGBTQ youth, and others, we see those numbers either dramatically or significantly higher than we see in the general youth population, or we have seen the increasing more dramatically among those populations. What this means is that we need to focus far more attention on our young people than we've ever done before. And as we are doing in this Policy Institute, the theme of our attention really needs to be around what we can do for our kids who are in school, both in the return to regular education and for those who will continue to do remote learning in the coming months and even years. We need to make certain that we are attending to all of their mental health needs as soon as they arise. Because if we wait, as we traditionally have done until stage 4, until crises occur, then mostly what we're doing is moving kids out of school environments to suspension, to expulsion, and not addressing their mental health concerns and conditions as they first emerge. So the schools can be and need to be a significant part of our solution to addressing the increased mental health needs that kids are experiencing and that we are experiencing across the population. And this would not be hard because historically we have underserved so dramatically our students in schools that we have a lot of room to make a difference. Not only do we have the opportunities to bring in community-based mental health resources, to bring them to bear for students on their educational programs, but in many areas we have the opportunity to bring in new resources into the schools themselves. Now, it shouldn't be any surprise to anybody how important these resources and how useful these resources can be to teachers who have been asking for them, to students who have been asking for them, to parents who have been asking for them. But what will surprise everybody is that to date, only about one child in every 30 who by NIMH definition has had a serious enough mental health condition by the age of 18 to negatively affect their learning. Only one child in every 30 has ever been identified for special education purposes as special ed eligible to get the resources they need, the services and the supports they need to succeed academically. So we have a lot of work to do, but a lot of ground that we can possibly cover. Not only have we seen the largest expansions of dollars into behavioral health services through stimulus legislation ever in the course of the past year, with more than $8 billion new dollars being appropriated to behavioral health, but President Biden's skinny budget included another $1 billion in the block grant alone for mental health that we are hoping can be applied toward upstream services. And the in excess of $100 billion being provided to educational supports for kids as they return from the pandemic, those dollars too can be allocated by communities to children and for the mental health and other behavioral health services they need. So this is the time to take action. It's the time to build awareness. It's the time to make investments. It's the time to make a difference. It's the time to change trajectories of lives. The time for action is today. It's now, it's this month, it's this year, and we're so happy you all are willing to join with us at Mental Health America in seeing that this comes to light and seeing that these activities and initiatives come to life. Thank you.
Thank you so much, Paul. The time is now to help school districts. You're 100% correct. We need to make tremendous action toward mentally healthy education, services, and supports. And the speakers on our first panel, Reopening Schools, will make this case. Please welcome leaders in the school mental health research, programmatic, and policy fields. And following the Reopening Schools panel, MHA's Sydney Daniello will share 6 principles that we found essential to ensuring a robust and comprehensive school mental health framework that supports staff and students and draws on community mental health resources. I'm really excited and honored to be joined by 3 national experts on school mental health. And I will get right into the panel. We're just really grateful to have Elizabeth, Sharon, and Joyce with us today. I encourage you to Google them. They've done some amazing work. Elizabeth Cook is joining us from the Alliance for Healthier Generation. Sharon Hoover is joining us from the National Center for School Mental Health. And Joyce Dorado is joining us from University of California, San Francisco. Let's get right into it, ladies. So, Elizabeth, assessments are an important tool for kind of making systems reforms, because you have to know the problem before you're going to try to diagnose it. Can you tell us a little bit about the importance of assessments, and in particular, the RISE index?
Yeah, I'm happy to, Karen. Thank you so much for this question. And thanks for having me today. I wanted to start by talking about why assessment is so important and what it is and also what it isn't. Assessment is a tool. It's not an intervention. It's intended to give schools and district teams a space to have meaningful and honest discussions about what's really happening in the school community, so that they can recognize what's going really well and prioritize what steps need to happen to make the changes that they want to see, and then monitor whether or not those steps are working. In a nutshell, assessment helps us monitor three big questions, right? That we should all be asking ourselves when we're implementing anything, right? Whether it's a program or practice or a new policy. How much do we do? How well do we do it? And is anyone better off? And if so, who? So one of the assessments that we have here at the Alliance for a Healthier Generation is called the RISE Index. It's one of my favorite things to talk about, and I have the great privilege of being the lead author of it. In a nutshell, the RISE Index is a self-evaluation and planning tool focusing on key best practices in improving social and emotional health and well-being of students, and also, and very importantly, of staff. Schools and districts can use the RISE Index to identify strengths and priorities in social emotional health so they can develop plans of action that are really meaningful to what their context and what their needs are, and also manageable, so able to be implemented in a way that can actually work and be sustained, and then track their progress towards these goals. It was built with a really intentional focus. I'm a practitioner. I'm a school psychologist by training. I was in the field for over a decade. I worked at the Department of Ed before coming to the Alliance in Wisconsin, before coming to the Alliance for a Healthier Generation. And so, for me, it really felt like the field needed something that was user-friendly, easy to understand, and that flexible enough so that any school, regardless of your priorities or your location or your school community makeup, that they could see their path to improving student and staff mental health and well-being. The RISE Index has two versions, one for schools and one for districts. Both versions of the RISE Index are broken out into sections and are short, 40 questions for the school, 30 questions for the district, and people can pick and choose which ones they want to work on, what they want to do. You can do the whole thing, you can do one section. It's really very flexible and up to what the needs are of the school and district. So in addition to calling out best practices in student social emotional health, like social emotional learning, mental health intervention, establishing safe and supportive environments, there's also a really explicit section in each version dedicated to staff well-being. And I really want to pause here and emphasize this, because we know that having a positive relationship with adults, especially educators, is a huge protective factor for youth and actually increases student achievement. And we know that teachers are stressed, they're burnt out, and they're leaving the field at really high rates. And so if we care about student mental health, we have to attend to the mental health of the adults that are tasked of supporting them. So then this brings me to kind of, I think, the purpose of the panel, right, which is to really think about policy, right? What are the policy solutions that we're driving forward here? And, from my perspective, we know the best practices in promoting social emotional health, right? And I would actually add, these practices also promote student achievement, which is critical. Among things, trauma-informed approaches and practices is a high evidence-based practice, which my colleague Joyce Dorado will talk about next. Explicit instruction in social emotional skills, inclusive and diverse environments where student identities are honored, strong mental health literacy, prevention and intervention, and lots of collaboration amongst the entire staff community is really what works, right? And we know it. What we need then is policy that promotes not just what works, right, but also supports districts in sustainably implementing these practices. So to me, this translates into providing necessary funding allocations for training, technical assistance, and coaching. It also translates to me to de-emphasizing traditional accountability metrics as the best or only way to measure, sort of success. And we need these policies and allocations to be stable, because if we're going to turn the curve on student mental health and student achievement and opportunity gaps for our youth, it's going to take time to plan, to collaborate, to innovate, and eventually get the outcomes that we want to see for all our youth. And we can't do that if everyone is really stressed out about whether the game is going to change or whether or not they're going to get dinged for not meeting a one point in time assessment benchmark. So that's why this sort of stability around that is really critical. Finally, I would love to see some legislation focusing on developing and maintaining a strong, diverse educator talent pipeline and resources dedicated to ensuring staff are well paid, well trained, and well supported. And so for me, this is where the RISE Index can really be the most supportive, right? We can help schools figure out what they need to do and how to do it. What they need is the resources and supports to make it happen. Thanks, Karen.
Elizabeth, you did a whole lot of subject matter in a very short amount of time. I think you probably gave us the most information in 5 minutes that I've ever heard. So thank you.
Welcome to Elizabeth Cook. It's very on brand for Elizabeth Cook.
I think you were very concrete in sharing what resources school districts need from policymakers, as well as how important it is for that funding and investment to be sustainable over the long term. So as policymakers are looking at appropriations bills and as ESSA is reauthorized, I think these are things that they can keep in mind. Joyce, I would like to turn it over to you now. You have the 5-minute challenge, and it's okay if you go over by a minute or two, of course. But we're so thankful for the work that you've done in promoting and in educating about the importance of a trauma-informed approach within schools. And we wanted to know what principles kind of go into that might be replicated, that other communities and even states could, and maybe even federal government could incorporate into policy that would ensure we have a different look or approach and perspective to how we're creating education spaces and how our communities are being built.
Great, thank you so much for the opportunity to contribute to this panel. So our program, UCSF Healthy Environments and Response to Trauma in Schools, or HEARTS, utilizes 6 core guiding principles. And these are grounded in research on trauma healing and resilience. And they can be applied, we believe, to, and we've been applying them over the past 12 years or so, to creating safe, supportive, and equitable school policies using this trauma-informed lens. So I'd like to just briefly touch on them here. And if you're interested in learning more about that, this policymakers can learn from our website, hearts.ucsf.edu. So the first principle is just about understanding trauma and stress, right? So we really have been going through this collective trauma in this pandemic. And when we're making plans for the fall, I think that policymakers really need to take into account the effects that trauma has not just on students, but on staff, on individuals, on relationships, and on organizations as a whole. So just a tiny bit of brain science: when we as humans feel unsafe or threatened, our thinking and learning brain largely goes offline and our survival brain takes over, and it triggers the fear response of fight, flight, freeze, or appease. And when we're triggered, we lose access to the skills and knowledge that we normally have, and our ability to do our job, to learn, to teach plummets, right? So applying to where we are in the pandemic right now, because we have been, so many of us have been under this sort of chronic state of threat due to the pandemic, many of us are much more likely to be easily triggered into a fear response by things that aren't actually dangerous, but remind our brain of danger, like hearing somebody clear their throat or being around other people or some noise or feeling a lack of control. And then what happens is we get triggered into these fear responses. And it's important to know that those behaviors that come from that triggered, dysregulated feeling are not on purpose behaviors. They're not willful, defiant behaviors. They're actually the survival brain taking over, right? And it's really important to remember, policy members and all of us to remember, that this can happen to students and to adults. And the more power that we have in relationships or in a system, the more our triggered behavior can cause harm. So this is true for school leaders, for policymakers. How do we make sure that we are not operating out of this survival brain, fear, sort of fear-related decision-making and such, and that we're putting in place policies that don't punish students for being in survival mode, right? And especially given that what we know is that trauma-affected organizations tend to actually have a tendency to become really fragmented, where one hand doesn't know what the other hand is doing, where decisions are made based on fear, where we get super overly reactive and punitive. And these systems can actually cause harm to students and educators. So how do we put in policies in place to try to mitigate that, right? Providing professional development training, consultation to administrators, teachers, and other school staff. Making sure that we are attending to not just student wellness, certainly student wellness, but also caregiver wellness and staff wellness. Thinking to ourselves as we implement policies, is this policy that we're trying to implement trauma-inducing or trauma-reducing, right? How do we also make sure that cultural humility and equity are central to what we're doing? How do we make sure that our policies are anti-racist and they actively combat the effects of structural racism and other structural oppressions? Because really, if a policy, practice, or procedure is not, for example, racially just, it's not trauma-informed and probably causing some harm. So more specifically, when we think about policies, how do we create policies that promote a sense of safety, connection, and agency for students, families, and educators? So when we say safety, we mean not just physical safety, but relational and emotional safety. How do we make sure that the policies that we put in place, for example, to establish physical safety don't inadvertently get in the way of creating relational safety, right? That like keep us so far apart from each other, or like we don't communicate with each other and now we can't trust each other and then nothing works, right? Because ultimately we are hardwired for those relationships, those caring and trustworthy relationships. This is one of our principles, compassionate, dependable relationships, are central. That we create conditions that help create opportunities for connection, that we as leaders and policymakers communicate well and are transparent and demonstrate caring for folks. And also, I would say, in terms of creating a sense of agency, there's lots of research behind this, but like we make better decisions as policymakers and leaders when we do things with people and not to them or for them. And when we involve the folks who are affected by these policies in the decision-making policies and the creation of these policies, and where we draw on the strengths and wisdom of folks who have been overcoming adversity for a very long time now, even pre-pandemic, right? What we know is that the pandemic has disproportionately affected Black and Brown folks and people who are under-resourced. How do we invite them to be thinking about how do we address this and lean into the strengths and wisdom that they have? Ultimately, I think we need to focus, this is the last principle, on resilience. I think we do need to lean into what folks' resilience are. I think it would be helpful to stop, for example, telling kids that they've had a lost year of lost learning, because actually we have learned a lot. And if we as policymakers, as leaders, can actually lean into what we have learned and act with this thoughtful intention and keeping these principles in place so that what we're doing is not inadvertently harming and instead helping, that we actually can get to a place where we as a society, as systems, are stronger and wiser and more compassionate than we were before.
Excellent, excellent, Joyce. Oh my God, you fit so much into such a short period of time, just like Elizabeth, discussing the importance of anti-racist and non-trauma inducing policies, as well as, I love your, the point about, the last point you hit about focusing on what we have learned. One thing that I heard from a young person that I some report did a video of was they said, you know, if I had to hit a wall and I broke down and I realized how much we need each other, and that connection and compassion is really a lesson that may have been learned much earlier on in Gen Z than maybe some of our older generations. So thank you so much for your work, for your advocacy, and for being just spot on and persistent and determined to ensure that not just California schools are changed, but that the whole nation is changed through trauma-informed learning environments.
Thank you.
Sharon, we're going to pivot over to you now. We would love to hear a little bit about some of the data that you've collected from districts who have either reopened or have stayed open and are returning to somewhat more normal operations, and how specific districts in Nevada and Pennsylvania that you've heard from are being very intentional about meeting youth where they are emotionally, socially, and that their mental health needs are being met.
Great, I'm happy to do that. Thanks so much for inviting me and allowing me to share some of the work that we've observed. As Joyce said, you know, there's been a lot learned this year from our young people, from our families and communities, and also the school districts who have rolled their sleeves up and really tried to do their very best in many respects to support the social emotional needs of young people and families. So I'll speak just quickly about some of the fantastic work we've seen in Nevada and Pennsylvania, and then give some ideas about policy implications of their work and the work of so many other states and local communities. So both Nevada and Pennsylvania have participated in our national center's National Quality Initiative, and they've engaged with other states across the country. And they came into this work right at the point where COVID was starting in many communities, and they still, again, rolled their sleeves up and committed to this work of advancing comprehensive school mental health systems at that time. So both Nevada and Pennsylvania committed to supporting at least 5 districts within their state to first assess comprehensive school mental health systems and the quality with which those systems were being implemented. So Elizabeth spoke earlier to the importance of assessment, and we could not agree more. Part of the process of our center engaging with states is having them take a look at their full continuum of supports for students and staff in the areas of mental health and well-being. We do that with a free online SHAPE system that was funded by HHS a number of years back for any individual or school or district or state or territory team to assess how their entire multi-tiered system of school mental health supports measure up to national performance standards. And several districts in Nevada and Pennsylvania first assessed how they were doing and then have been engaging in quality improvement. And I'll give you a couple of concrete examples from those states, so of kind of what they've done and some of the incredible innovation that they've achieved in the last year plus. So the Washoe County School District in Nevada supports about 64,000 students in over 90 schools across rural, suburban, urban settings. The district made the decision to open all schools in August 2021. Many students remained in a distance learning environment, but many were present in school. And when they reopened schools, they boosted mental health services and other supports to students to really meet their social and emotional and other health needs. And one of the primary ways that they did that I want to highlight was that they tremendously expanded their partnerships with a broad network of community behavioral health providers. So these providers expanded their resources. They provided an increased amount of services to young people and families, and they broadened their services to school staff so that school staff and students could get mental health supports right there on campus during the school day. And there are many ways that other districts can learn from this model of school community partnerships so that we're not relying entirely on schools to provide mental health supports to students, but rather really kind of partnering with our community partners to do that. In Pennsylvania, they similarly pivoted social emotional health during COVID. They released something called the Creating Equitable School Systems, a roadmap for education leaders, which had a real focus on the social emotional wellness for staff and students. And they're about to release a new learning series called Accelerated Learning, which will provide a process and systems to support LEAs as they open schools. And they are focused on trauma-informed principles and focusing on comprehensive school mental health as a key component of this learning series. And one of the areas that they really have lifted up is how districts can build and sustain comprehensive school mental health. So they're using a national course that was developed by the Mental Health Technology Transfer Center Network to guide districts in this work. So what can we take away from the efforts of Nevada and Pennsylvania and many other states? We know there are immediate needs that need to be addressed now, right? So we need to provide additional training, staffing, and as feasible, we need to address the anticipated increase in mental health needs with that staffing and training. We also need to provide immediate support to our teachers, and I predict that if we don't do that, we will lose a substantial number of them in the field. In collaboration with the Council of Chief State School Officers and the Healthy Schools campaign, we're about to release guidance to state and local education authorities on how they may consider allocating COVID relief and recovery funding to support student mental health. So just a couple of key points here. We know the one-time nature of the elementary and secondary emergency relief funds make them an excellent fit for investments in the capacity of SEAs and LEAs. This includes leveraging these funds to strengthen programs that create sustainable sources of funding. And Elizabeth highlighted that in the beginning. We have to think the long view. We have to take the long view, rather, in this work. But we can use these funds strategically to sustain funding. Second, it's important to invest in infrastructure, policies, programs, and staffing that work in concert with your state school-based Medicaid program. And to take advantage of the opportunity, SEAs and LEAs really need to come together to consider options for expanding school Medicaid programs and work with their Medicaid agency to leverage it. Third, it's not just about Medicaid. So several different funding streams can be leveraged to advance efforts to support student and staff mental health, and ESSER funds can be used to build the capacity of your SEAs and LEAs to effectively braid and blend different funding streams to ensure that there is sustainability. We would recommend that states issue guidance that is specific to their state on how to access these different funding streams, and perhaps even more importantly, really establish a statewide cross-sector partnership that can ensure that the funding streams are being well utilized. Invest in data systems, invest in policy considerations and mapping of what already exists in your program. And to kind of bring home the point of Joyce that she closed with, I'll just mention that I think one of the key investments that people need to be thinking about as an investment is meaningful engagement of young people, families, and communities in creating the policies and practices that are going to impact them. We have to think of that as an investment and not just something that we're inviting people into, but rather something we're actually funding. So I'll close there.
Wow, Sharon, just an incredible amount of information, just as Elizabeth and Joyce gave, and you shared some really key things that legislators can take back to their committees about the importance of allowing flexible funding, issuing guidance that would provide some guidance for schools that are drawing down funding, as well as something that just makes so much sense in the context of not only this program, but MHA's mission overall, which is including the people with lived experience or the people who are impacted as part of the people, or as part of the people at the table making the decisions and interpreting whether or not this will have intentional or unintentional effects on them. So thank you so much for highlighting the work in the school districts that seem to be nationally recognized and high quality in Nevada and Pennsylvania. And I just want to say thank you. Thank you, Sharon. Thank you, Joyce. And thank you, Elizabeth. I think this program will be very powerful in changing some or influencing some lawmakers who aren't quite sure what to do, but and might need some help. As well as hopefully the administration and other other politicals or elected officials who can have a hand in ensuring that the support that school districts need is there for them to meet youth where they are. So I'll close out there, and again, we really appreciate your time today.
Thanks so much, Karen.
Thank you.
Thank you.
Good afternoon, everyone. My name is Sydney Daniello, and I'm a program associate at Mental Health America. I'm so excited to follow that incredibly insightful panel and to discuss some of the guiding principles and highlights of MHA's upcoming school-based mental health policy report. The report covers policy on mental health education, school-based mental health services, and mental health sick days, and will include a number of resources and tools that can be used for state and local advocacy efforts for these topics. The report highlights 6 guiding principles that I'm going to discuss today that serve as advice to those looking to advocate and develop policy for school-based mental health. After going through these principles, I will also highlight and explain a little bit about one of the topics covered in the report, which is mental health sick days, and how this policy in particular relates to the importance of youth empowerment in mental health advocacy. The first guiding principle that we provided is to use a strengths-based, asset-driven approach when developing school mental health policy. Using this approach, well-being, resilience, connection, and inclusion should be the goals, rather than emphasizing safety and discipline. This is a shift away from the traditional health education framework because this approach gets at the idea that while not everyone experiences mental illness, everyone has mental health. The second piece of guidance highlighted in the report is to frame educational equity as health equity. This means emphasizing the connection between learning and health, including mental health, and using an equity lens to improve educational and health outcomes, particularly for BIPOC and LGBTQ+ students, through school mental health initiatives, as these students are often most effectively reached at school. This takes the principles of social emotional learning and applies a framework of equity and inclusion to meet the unique needs of all students. The next principle that we offer in the report is that empowering youth is a key measure of success. It is crucial to include youth in every stage of policy creation, including brainstorming and planning, understanding school and community needs, developing policies to meet those needs, and implementing those policies in a way that can meet young people where they are. Educating youth on the legislative process so that they can fully participate in policy change is a key factor in creating policies that students truly believe that they can benefit from. The fourth principle that the report advises is to work within or build on top of existing structures of state legislation or health education requirements, curriculum, and interests. Synthesizing and respecting existing efforts such as social emotional learning and suicide prevention helps to build momentum around the issues rather than trying to start from scratch. The second to last principle of the report is to consider implementation, evaluation, and ongoing innovation to be as important as initial policy. We believe it is vital to the implementation process to provide adequate technical assistance for mental health education with regard to effective curriculum, processes, and comprehensive training for the whole school community. Encourage innovation in school-based mental health services such as telehealth, digital tools, and new ideas generated by students and others. Consider evidence-informed approaches and measurement of outcomes to ensure all students can benefit. The final guiding principle that we included in the report is to leverage policy changes for a whole school, whole community, whole child approach. Conduct comprehensive assessments, address gaps, and connect to community resources to improve student mental health, resilience, and well-being. There is no one-size-fits-all policy that addresses school-based mental health, so it is important to factor in the unique needs and strengths of the community, school, and student body for which policy is being developed. I want to shift now into talking about mental health sick day legislation, which is one of the 3 major topics covered in the report and also highlights the key role of youth-led advocacy. Oregon's House Bill 2191 is an excellent example of both of these ideas. Passed in 2019, House Bill 2191 added mental and behavioral health to existing legislation on excused school absences, allowing students to have excused absences from school to take care of their mental health, just as they would their physical health. The entire legislative process, from the birth of the idea for the bill, to the drafting of the bill text, to all the advocacy and lobbying meetings, was led by a group of young mental health advocates called Students for a Healthy Oregon, with support from Providence Health. Supporting and empowering these young people was crucial to getting the bill passed because the students were able to create and advocate powerfully for a bill that they came up with and actually believed would help. Other states followed closely behind Oregon, passing similar legislation, often driven by young advocates within their respective states. Additional states that have passed legislation regarding excused absences for mental health include Colorado, Maine, Utah, and Virginia. Advocacy organizations and others interested in helping young people advocate for what they need can support youth advocacy efforts by actively seeking out young people who are already doing the work, such as Students for a Healthy Oregon, and offering guidance or resources as needed, allowing young people to be empowered to create the changes that they want to see in their communities. This report is scheduled to be released to the public in mid-July, so be sure to keep an eye out for it as we get closer to that timeframe. Amplifying the voices of young people is incredibly important in order to address youth mental health needs. So I'm very happy to say that we're going to continue to hear from a number of young mental health advocates throughout the day. The next two speakers we're going to hear from will continue to address youth empowerment and will discuss innovative ways of meeting student mental health needs through school-linked mental health services. I'm looking forward to a great rest of the afternoon. Thank you.
Well, thank you for the tremendous insight, Sydney. We look forward to the report release in mid-July. We'll now hear from youth advocate Angela Wallace, who's been instrumental in helping states across the nation pass school mental health legislation, and she'll talk about why this matters so much to her. She'll then be followed by a former superintendent of Minneapolis Public Schools, Bernadette Johnson, who will discuss ways she worked with community stakeholders to begin and broaden the reach of school-linked mental health services in Minneapolis to catalyze a generation thriving, not just surviving.
My name is Angela Wallace. I use she, her pronouns, and I'm currently a junior at Bowdoin College. And in analyzing what led me to mental health advocacy work, it really started when I was in second grade. So from second grade to the 12th grade, I was a student in the Massachusetts public school system, specifically at Sharon High School. And, you know, at Sharon High School, I noticed that there was a strong pressure to succeed and to always be on top of things, not really talk about your issues. And if people ask if you're okay, you kind of just say, I'm okay, even if you're really not. And as a Black woman specifically, I've always been taught by society to, you know, shield my feelings and not really ask for help when I really need it. So at Sharon High School, I found myself participating in, you know, activities that really didn't bring me joy. I found myself pressuring myself every day to constantly get that A and nothing less. And it was really, really difficult. And finally, you know, my mother told me to go to therapy, and I finally did. It took a lot, especially because I didn't really know much about mental health and anything revolving around mental health. I always knew of the stigma saying that you shouldn't ask for help because it's a sign of weakness. But over time, I found out that's not the case. And I really was disappointed in my school system for not discussing mental health more. So given that background story, ever since then, in 2019, a fellow Bowdoin student, his name is Lucas Johnson. He's amazing. He's also a junior like me. And he encouraged me to testify at the Massachusetts State House in favor of bills that would implement mental health education in Massachusetts public schools. And from there, we just kept continuing this work. And I really, really did love it. And I feel like I've found my voice over time. And I also work with Mental Health America, and that's where I feel like it's been a nice space where I could be vulnerable and share my own experiences that I typically could not share before. And additionally, I've reconnected with classmates at Sharon High School who have opened up about their own battles with mental health, and they've been amazing, and we've been able to connect on a different level. So for me, mental health advocacy is so important for individuals like me to know that you're not alone. There are so many resources out there for you, and I want to encourage people to be a better ally for those who really, really need it. Thank you.
Hello, everyone. I am Dr. Bernadette Johnson. It is such an honor to be here with you for the annual National Mental Health Policy Institute. I first want to recognize Sue Abderholden, the Executive Director of NAMI, and the other community organizations, and Jim Johnson and other district leaders who joined me at the table to think about how we could optimize our unique organizational skills to support the mental health of Minneapolis public school students, and in turn, to create the mental health model that I will share with you all today. Let me begin with a question. Is there anything more important than the well-being of our children? I imagine all parents would quickly answer no, and that would be echoed by grandparents like me and most others. We have all known for a long time that our children are facing challenges to their mental health. This organization has often documented these needs, and after this last turbulent year, those needs have become even more pronounced and present us with even more urgent calls to attend them. And yet the barriers to doing just that are familiar and remain. It is in fact those obstacles that I would like to address today. Let me start at the end. This year, mental health clinicians from our community will work alongside educators in every school in Minneapolis public schools. Their services will be available to any student, regardless of family's ability to pay. Many, not all of our immigrant children will be able to receive the services in their home languages. Again, many, but not all will see a clinician who looks like them. It is a journey that began in 2004. A journey joined by teachers and administrators, mental health agencies, clinicians, students, families, and advocates, politicians, insurance companies, charitable foundations, and researchers. From the beginning, all were involved. All signed on to the goal of ensuring that children had access to the mental health treatment they needed and that schools become a place that better supported their well-being. All worked to come nearer to the solution. It meant acknowledging barriers each erected. It meant being transparent. At the beginning, through policy and rules, mental health services could not be delivered and paid for in schools. Mental health agencies were afraid to commit the staff. Insurance companies refused to pay for services delivered on school grounds, and politicians were afraid to open the floodgates of accessibility. Schools did not see their role as to provide treatment, and the union did not want other professionals working in the school taking away their jobs. Issues of structure, effective and culturally competent treatment, payment, and privacy were all like castle walls, high, impenetrable, and ancient. But the children, parents, and teachers were naming the need. And so those are the barriers, each named, each supported by policy and rules. Who would do this? Who will pay for it? Do I dare trust that if I give up my power, which I've carefully crafted the rules that have been made to protect my interests, others will not take advantage of me? Do I trust I will not be left holding the bag, expected to change too much, be made to feel uncomfortable? Well, as superintendent who participated in the development of this program, I can tell you, those are real questions. But what I found was that there was enough people who heard the first question loudly. Is there anything more important than the well-being of our children? And they were willing to begin that journey. So let me tell you a short version of our trek through the unknown. As the superintendent of Minneapolis, I was trying to shift the experiences and outcomes for all students, but especially my BIPOC students, who for every indicator of school success were at the bottom, and for every indicator of school failure were at the top. I was seeing how the absence of mental health support was having an impact on students' experiences and outcomes in schools. I saw a persistent rise in school suspensions, low academic achievement, increased school absences, and referrals to special ed. I began to realize how the trauma that many of our students were experiencing in their community was impacting how well they were doing in our schools. That realization is clearly evident in our city of Minneapolis and other cities across this nation. Our students, and I mean our share students, are experiencing these increased traumas. They are isolated from their peers and other social networks due to COVID. They're experiencing increased gun violence in their neighborhoods that lead to loss of life. You all know about the killing of George Floyd. And here in our city, we have seen an increase of children being shot and barely hanging on to life. In Minneapolis right now, we have 4 children in the hospital from gun violence. The youngest was shot while jumping on a trampoline at a birthday party. All of us know the consequences of COVID and bringing loss of life to our families, and mine included. And if one of those 4 children just passed away last night. Like most school districts, Minneapolis didn't have the level of services, support, or expertise to adequately help our students address their mental health needs, to develop the resiliency and skills to survive and ultimately excel in our school environments. This was especially true for our BIPOC students. The traditional model of families seeking mental health support outside of school was not a model that worked. Families struggled with engaging in services due to work and insurance issues. And when they did, the average course of treatment lasted only 5 sessions, often not long enough to be effective. Additionally, there was little contact between the agency and school, so students were not supported in practicing their newly acquired skills. We worked to engage the system and partners who are already in the field of mental health in our community. We didn't want to create a new parallel system. Local organizations, both public and private, who already had the sanctioned mission to provide mental health services for families that had the structures, systems, and processes already in place, joined us at the table to do what they did best. We all came to the table as experts in our own field while understanding the overlap of our responsibilities to ensure that our children had the foundation and sense of well-being and the education they needed to reach their potential. And yes, we all came to the table with our checkbooks, guided by the principle that we would accept responsibility for paying for the services as appropriate for each entity and work together to manage any excess cost. By engaging with community providers, we were able to bring agencies that already had visibility and credibility in the community, some that had already been around for decades. Some had special expertise in providing services to specific communities, especially undeserved communities like the African American, Latinx, Indigenous, and immigrant communities. Because they were known in the community, they came with the community's trust, which was critical to overcome the hesitancy to engage in the services and to address stigma. We gained one more benefit. The mental health agency also had the same workforce challenges we had in K-12, and that is a diverse group of providers and clinicians. These agencies took on the additional responsibility of providing training and professional development of clinicians, especially clinicians that look like communities we served. To aid the schools in providing an environment that was better able to support all students, the school-based mental health clinicians set aside about 1/3 of their time to provide service to the school staff. This involved consultation about school strategies and classroom strategies for students, professional development on topics such as typical child development, culturally specific practices, trauma, anxiety, depression, and strategies for identifying mental health concerns. Schools were required to set aside time for the mental health clinicians to provide this professional development with the end goal of creating classrooms which are more supportive of all students. One final but important note, privacy is a critical feature of bringing mental health services into the schools. By engaging the community providers, we were able to ensure that the same standard of privacy required in all health settings will also apply to our program. All information and records belong to the agency and only shared with the permission of the parent and as necessary to support the child in the school. We started with 5 schools in 2004, and when I left in 2015, we were at 38 schools, and based on the information shared with me recently, services are now located in all schools. Our data has demonstrated, and we educators have seen the result of the school-based mental health model: improved attendance, a decline in suspensions, an improvement in academic outcomes. Teachers reported improved behavior and engagement. Children experienced improved well-being. Parents reported that their children are better off. As a policy proposition, a return on investment in supporting our next generation reaching their dreams and potential, I call it a success. A risk worth taking, an effort worth making. a question worth answering. Nothing is more important than the well-being of our children, our next generation. Thank you for your attendance in this conference.
Thank you so much, Bernadia, for discussing the steps schools can take to overcome accessibility barriers that underserved youth and families may face. We will take a 5-minute break now, and when we come back, you'll hear from MHA's Debbie Plotnick, who is moderating the panel Assessments and Innovative Solutions, featuring our own Oklahoma affiliate. By the way, if you are an MHA affiliate attending pre-con tomorrow, be sure to take a photo in the virtual photo booth. We will see you back here in 5 minutes.
Hello, everyone. I'm Debbie Plotnick. I'm Vice President of State and Federal Advocacy for Mental Health America. And I want to welcome you to the panel, Data and Innovative Solutions. There are successful ways to collect and use data to evaluate mental health needs of adults and youth on school campuses, and to put in place policies and plans that grow mental health literacy, services, and supports. This panel will explore how to do these things with some terrific experts. We have Terry White, the Executive Director of MHA, and that MHA is known as the Mental Health Association of Oklahoma, but MHA of Oklahoma. Jill Bonenkamp, and Dr. Bonenkamp is Assistant Professor at the National Center for School Mental Health. And Ben Ballman, and Ben is a student advocate, and he is also from Maryland. So let's get started. Terry, please tell us about your time in state government and describe for us how you and the State Department of Education approach school-based mental health in schools and why you did so. But while I'm asking you questions, I've got two more. So let me put them aside and you can get to them after that first one. And secondly, can you tell us more about how schools can promote the understanding that mental health is important, and not only important, but essential part of health? And then tell us a little bit more, please, about Mental Health America of Oklahoma's coloring book. We want to hear about their special coloring book on mental health and feelings. And of course, that leads us into why mental health literacy is so important and how schools can promote more understanding around its importance.
Thank you, Debbie. Those are great questions. So during my 13 years as commissioner for the Oklahoma Department of Mental Health and Substance Abuse Services, we partnered with schools to provide no-cost training and technical assistance for school administrators, teachers, counselors, and parent-teacher organizations. One of the fantastic programs that comes to mind was the department's Youth Mental Health First Aid Program. It teaches school personnel how to recognize the signs and symptoms of common mental illnesses and substance use disorders, how to de-escalate crisis situations safely, and how to initiate timely referral to treatment resources within the community. By partnering with schools, we helped to ensure that there were safe places for students to start connecting to treatment for issues such as anxiety, depression, substance abuse, and thoughts of suicide. The fact is that for Oklahomans who are between the ages of 10 and 34, suicide is the second leading cause of death. That's why during the 2017-2018 school year, the department trained more than 3,000 Oklahoma educators in 43 of our 77 counties in suicide prevention. Since 2011, the department's trained more than 15,000 school personnel. In addition to working with the State Department of Education in Oklahoma, it was also really important that we worked with our local superintendents, because in Oklahoma, superintendents hold a lot of the authority over school districts. And so our largest school district is the Oklahoma City Public Schools District. And I partnered very specifically with the superintendent for Oklahoma City Public Schools, Sean McDaniel, to do a deep and wide partnership on mental health. We created a plan that worked in conjunction with the United Way of Central Oklahoma, the Oklahoma City Chamber, and the Oklahoma City Public Schools Foundation called Embrace OKC. And the idea was to work at prevention, early intervention, and treatment at all levels of public school systems. So we had plans for elementary schools, specifically early elementary schools, later elementary, middle school, and high school. And it was everything from prevention programs like Botvin's Life Skills and the Good Behavior Game to actual embedded social workers who could provide treatment or make referrals for ongoing services. For your second question, how can schools promote understanding that mental health is essential and part of overall health? When you think about it, mental health and counseling services are in schools are an ideal place for many parents and kids because it's a convenient place to access quality care in a private, safe, and confidential environment. Many school districts have licensed mental health providers placed in primary and secondary schools through partnerships with a variety of children's mental health organizations. With parental approval and consent, children can be provided high-quality mental health assessments and treatment at school, either in person or virtually through telehealth. At Mental Health Association Oklahoma, our free student mental health screening is actually an entire youth wellness program that identifies general health and mental health concerns for 6th through 12th graders in our state. At school or virtually, the student completes a computer-based survey of mental health concerns. And if that screen identifies a mental health concern, our screener right there at the school, including, and it looks for suicidal thoughts and behaviors as well as mental health concerns, our screener right there will work with the parent and make sure that there's a plan to connect that teen or that 6th through 8th grader with the necessary supports they need and treatment. And finally, everyone involved in a child's education plays a key role in breaking down the stigma of mental illness. To reduce stigma, there must be more education and more story sharing. With this in mind, I'm excited to share that Oklahoma, with the advocacy work of Mental Health Association Oklahoma, just passed legislation which requires the State Board of Education to mandate that all schools provide instruction in mental health, emphasizing the interrelational issues between physical and mental well-being and how they're all connected. Beginning with the 22-23 school year, in collaboration with the Department of Mental Health and Substance Abuse Services, the State Board is required to adopt and approve age-appropriate curriculum for students in grades K through 12 in Oklahoma. Local school districts may enter into agreements with nonprofits or other community partners to provide this education to students. This kind of legislation reinforces the importance of making mental health a natural part of how we talk about brain health or heart health or lung health or any aspect of health. We need to do the anti-stigma work that's very much needed so students view this the way they would talking about treatment for diabetes or any other physical health condition. And that's how we change and save lives in school. For your third question, I'm really excited that you asked about Mental Health Association of Oklahoma's coloring book. During Mental Health Awareness Month, which we all know is in May, our association offered a children's mental health coloring book to encourage everyone to create an environment for healthy minds to thrive. To do that, we created a free to download mental health coloring book for kids. You can download it on our website, which is MHAOK.org. I love this mental health coloring book because it's a fun activity for children and their parents or grandparents to work on together. It's also an opportunity for a parent or a guardian to talk to their child about what it means to have a healthy brain. It can also be used by teachers in schools to begin the conversation about mental health. It's age appropriate, and it actually helps equip a child with the ability to recognize and communicate their feelings to the people that are most important in their life. And sometimes that's a hard thing for a child to know how to do. And we as the adults in their life have to give them that opportunity and teach them how to do that. And this coloring book is a great mechanism to do it. And it's perfect for parents and school personnel. So we're really excited to share it with everyone.
Jill, tell us more about how school districts can learn about where they are. What kinds of ways can they assess the mental health needs of their students? And what more can they do once they figure that out?
Debbie, thanks so much for this question. And I'm so thrilled to be with you all today. I'm Jill Bonenkamp. I'm an assistant professor at the National Center for School Mental Health at the University of Maryland School of Medicine. And I'm a clinical and school psychologist by training. And these are great questions. And I look forward to sharing more about our center and specifically talking about free resources that are available to do just this, to answer this question, to help schools, districts, and states to improve their mental health and well-being supports for the entire school community. So first, let me go ahead and tell you a little bit more about our center. The National Center for School Mental Health at the University of Maryland School of Medicine is funded in part by the Health Resources and Services Administration. And one of our charges is to lead the National Quality Initiative focused on comprehensive school mental health services. Our mission is to strengthen policies and programs in school mental health to improve learning and promote success for America's youth. We focus on advancing school mental health research, training, policy, and practice at the local, state, and national federal levels. Our center is co-directed by Dr. Sharon Hoover and Nancy Lever, and I'm core faculty at our National Center. At the National Center for School Mental Health and as part of the University of Maryland School of Medicine, we're committed to conducting all of our work through a social justice lens. We will continue our work to support culturally responsive and equitable practices in school mental health, with a specific focus on Black, Indigenous, and people of color. And further, we recognize that through addressing structural and systemic inequities long present in the education and mental health systems, that school mental health has opportunities to develop and model equitable and anti-racist policies and practices. We're committed to learning, healing, and growing together. And as I talk about these free resources that are available for school systems to think about how to improve their systems and move forward and make sure that there are supports for all students, please know that these resources and these things I'll be talking about are grounded in this commitment. So before I dive into a specific resource, I just want to do a level set and ground us in what we mean by comprehensive school mental health. So this is multi-tiered systems of supports for students and families and educators. So we operate from this multi-tiered system of support framework with the following guiding principles. We focus on cultural responsiveness and equity in all of our systems, making sure that youth and family partnerships are at the center of our work, that we're thinking about education and mental health integration, implementation science and best practices, funding and sustainability, and very importantly, advocacy and policy. And this just gives you an example of, as I go into our free resources to help school systems think about how to improve their comprehensive school mental health, we're going to be looking at and thinking about specialized instructional support personnel, collaboration around family, school, and community partnerships, needs assessment and resource mapping, multi-tiered systems of support, thinking about data and screening and funding. And this just gives you an example when we're thinking about our multi-tiered system of support, that we're thinking about tier 1 supports or universal promotion of positive social and emotional behavioral skills and wellness for all students. We're thinking about tier 2 supports in early intervention for students identified through needs assessment as at risk for mental health concerns. And then, of course, our tier 3 supports, thinking about targeted interventions for students with serious concerns that may impact functioning. All right, so this key answer to this question of here, if you are a school mental health system, a school, a district, or a state that's really interested in moving this work forward, knowing that we have these intense mental health concerns and needs coming off of the pandemic and in this very trying time, the SHAPE system is your place to go. So the School Health Assessment and Performance Evaluation System, or the SHAPE system, was developed by our National Center team as part of the National Quality Initiative, and it was developed in partnership with the field. It is a free, let me highlight that, free, everything about it is free, public access, web-based platform that offers schools, districts, and states a workspace and targeted resources to support school mental health quality improvement. And so this is the place that to answer this question where you need to go. So I'll tell you more about SHAPE and show you some of the features that are on here. So on SHAPE, there are many features that schools, districts, and states can use. And the way that this typically works is that schools and districts can go in and map their school mental health services and supports so that they can identify what they have in place. They then can think about their system quality using national performance standards. So they go in and they use our national quality assessment, which I'll talk a little bit more about, and they can really see comprehensively when they're thinking about improving their system, where are areas of strengths and where may they want to make improvements. They'll receive a customized report and strategic planning guides and resources after doing these assessments. And they can access a number of resources, including our screening and assessment library. And there are lots of opportunities for districts and states to collaborate via dashboards with schools and districts in their region. So I'll give you a quick tour of what some of this looks like on SHAPE. So there are options to sign up as an individual, school, district, or state. As I mentioned, it's completely free, and SHAPE has been used by over 15,000 schools in all 50 states. And I encourage you to explore today, or encourage your constituents to get started. And so I'll just show you some of these features. So this is the school mental health profile, where schools can enter information about their staffing, services, and supports. A key resource is the National School Mental Health Quality Assessment, where systems can assess their system on these quality domains listed here. There are a number of indicators, so it really is a comprehensive assessment. If you really want to think about where are strengths, where are areas for growth, this is the place to go. This gives you an example of what this looks like, your dashboard as you're completing the quality assessment. Each question includes best practices for comprehensive school mental health to move you forward. And this is an example of what these custom reports look like. So you'll immediately receive summary reports that give you an overall score and on your entire assessment. There's also a strategic planning guide at the end that helps you after you've done this assessment to move forward. There's an entire resource library organized by domain around with key components of school mental health to help you move forward. After you've done your assessment and you're thinking about your next steps, the resources are right there. And you can organize them by domain. We also have a quality guide series that contains background information on each domain, best practices, and action steps. And this just shows you what your dashboard looks like and how you can collaborate with other schools and districts. And we also have a screening and assessment library, another great feature of SHAPE. There also is an entire section on trauma responsive schools, similar assessment reports and resources. And we also have a number of resources for states. So states can complete a school mental health profile to look at how they're doing in terms of comprehensive school mental health and link to resources. And so this just shows you how this process works, that a school or district can go in and complete the school mental health quality assessment. They can use targeted resources, and they can collaborate using state and district dashboards. We also have a new resource here, which is the state policy, mental health policy map. This is mapping what policies for key areas of comprehensive school mental health look like across the country. If you click on these, they link directly to policies in these states, and is a great resource to move you forward. So thank you for this question, and thank you everyone who is watching for all of your work to move forward comprehensive school mental health. And I definitely encourage you to get started in the SHAPE system and start to dive into many resources that are available there. Thanks so much for having me.
Ben, you have collected and organized data that shows what students who are seeking mental health supports so desire. So we want to hear about that data, and we want to hear what you have found. We also would really like to hear about how policies can be shaped so that students lead evaluations of their schools mental health policies, and how can the students again lead that evaluation to assess whether the school is actually meeting the needs that the students feel are most important.
I'd love to tell you a little bit more about the survey that I had several students from across Montgomery County, a district in Maryland, fill out about their counselors and the counseling department in the public school system in Montgomery County. This kind of all originated from the fact that, I was seeing students struggling from mental health, and Many students didn't know where to go to seek support. A lot of times students were lost, and they came to me, they came to other friends, but strangely, they weren't going to their counselors, the place that you'd think that many students would go to seek support. So after some time and talking to students, I realized that many students had horror stories about the counseling department. They were turned away, they were rejected, they weren't given the support that they properly needed. So I decided to see if I could do anything about it. I wanted to learn more about what was going on. And to do this, my mind kind of went straight to Google Forms. It's a pretty easy way just to collect a lot of data. So essentially what I did was I filled out this Google form asking several questions about different aspects of the counseling department. How effectively do they support students' mental health in urgent situations and non-urgent situations? How well does the counseling department reach out to students? How well do they follow up and keep relationships with students? And all these different aspects about it. And for several days, I canvassed sending this Google form out to as many people as I could. Eventually, I got back almost 500 responses from all different schools in my county. And immediately I got back a striking response from students where they genuinely did not feel like the counseling department was supporting them the ways that they needed. Many times they thought the counselors didn't have enough time for them, that students had to work to squeeze into a counselor's schedule, that counselors were apathetic to what was going on in these students' lives and were just trying to, get down the checklist and get them out the door as soon as possible. And so this was kind of the first step I took into, learning more about these issues that was going on. And I was able to use this really convenient, really free piece of technology that allowed me to get responses from students all across my area. And, of course, I took that and, I brought it to the counselors at different schools and tried to learn more from their perspective. And that kind of culminated with a letter that I sent along with other students to the superintendent and the Board of Education in my county. And of course, that didn't necessarily go so well. Though I did have meetings, I never saw a real change occur. I was able to collect a lot of data on how students were feeling using this piece of technology. And so to talk a little bit more about policies in the future, I really think the most important policy to focus on would be the education of students in regards to their power. Now, let me explain a little bit more what I mean by students' power. In high school, we only have one class that teaches us about government, and that would be AP Government. And that really focuses on government in a broad sense. It focuses on the federal government and bureaucracy in an ideal sense, but it doesn't go into the nitty-gritties of day-to-day life within the government, and it doesn't focus on the local and state governments whatsoever. So even though I had all this data that I collected and all the student support saying that there needed to be a change, and all these students giving me practical changes that could be implemented, I didn't really know what to do with it. I didn't have the proper education to make the changes that students need. And so that's what I mean when I say I had the power to find all these students who wanted to make a change, who needed support, but I dropped the ball a little bit in that I didn't have the education that I needed. So in a policy sense, I think this should be altering the education that students receive within schools. Having a heavier focus on the systems of government, the intricate process when a bill turns into law, the practical approach to government, in a sense of the quid pro quo and the use of leverage that is very commonplace. And also the process and impact of advocacy, because students have a lot of power to advocate for themselves, yet many students simply don't know how. And also, this doesn't need to be implemented necessarily into policy. There's a lot that can be done outside of the policy sense. We could have workshops to educate students about their power, about what they can do to advocate for themselves. We can have infographics to disperse among students to give them quick and easy tips about how to make the changes that they want to see. And also having a lot more easy to access information online. So during this process, most of my time, I was relying on a combination of common sense and Google searches, and realizing that a lot of this information not being taught in school and not even being really readily available online needs to be dispersed to students a lot more. Students have a lot of power, and it's our responsibility to help them find it.
Ben is 100% correct in stating it is the job of our education systems to help students find their power and understand their responsibility and how they can influence systems in which they operate civilly, politically, and otherwise, so that systems may reflect the will of the people and keep up with the times. With that said, I'm very excited to introduce MHA's Kelly Davis, who will present Ben Ballman with a special honor. And following this awards presentation of our inaugural Youth Advocacy Award, you will hear from Chelsea Prox of the American Federation of Teachers for a special fireside chat exploring ways to meet educator staff needs as part of the overall goal to ensure student mental health needs are met. Take it away, Kelly.
Hi, everyone. My name is Kelly Davis. I'm the Associate Vice President of PR and Youth Advocacy at Mental Health America, and I'm incredibly excited to be here with you all today to introduce our first ever Youth Advocacy Award. The Youth Advocacy Award recognizes a young person making a difference in their community through policy changes at the local, state, and national level. Youth empowerment and leadership is critical to long-term systems and societal transformation. MHA is proud to honor the brilliance and determination of young leaders, changing the present and future of mental health and well-being, not just for their peers, but for everyone. As with MHA's founding by Clifford Beers, young people also are incredibly important leaders using their lived experience to step up and make a difference. I'm so excited to present this award today to an extraordinary example of just that, Ben Ballman. Ben is the co-founder of DMV Students for Mental Health Reform and a member of MHA's Young Mental Health Leaders Council. He also was an integral voice in MHA's work on determining K-12 mental health education policy across the country. Just like Clifford Beers and just like so many of the young people that you're hearing from today, saw something was wrong in his community and did something about it, and has changed his community, his local schools, is now making change at the state level, and is continuing to lead at the national level as a model for other students and young people who are interested in making a change as well. I'm super excited and grateful for his work, but also excited to see his future. He'll be attending Vanderbilt in the fall, so if you are in the area or connected to the school, definitely connect with Ben. And he will be doing amazing things just as he has done before. So again, it is my honor and privilege to present this award to Ben for all his work. Thank you, Ben.
I'd like to sincerely thank Mental Health America for this award. It genuinely feels incredible, if not a bit absurd, that I was selected. It feels a bit absurd because when I think about the work that I've done within student mental health, it has never been an individual effort. Everything that I've personally accomplished has been directly because of other students who want to make a change. From the very beginning, with my research into Montgomery County's counseling department, students came together to give their opinions on the mental health services they're supposed to receive. This initial effort from students eventually snowballed all the way into DMV's Students for Mental Health Reform, where students from all over the DC, Maryland, and Virginia area contribute to support the mental health of their peers. This award is the result of all the work that students put in to support one another, so my thanks goes out to you all. In addition, I'd like to thank Kelly Davis, Karen Howard, and everyone on MHA's Youth Mental Health Leaders Council. The support and guidance I receive from each of you put me in position not only to be a bug on that legislators swipe away, but someone that can make a meaningful difference in the lives of others. Thank you.
I'm Chelsea Prox. I'm here on behalf of the American Federation of Teachers, where I direct the programs for children's health and well-being. I'll talk a little bit more, hopefully, about my background, but briefly, I'm a former teacher with a master's in public health, where I wear both hats at the AFT.
I'm Laura Bay. I'm with Mental Health America. I serve as their public policy chair and a member of their board. I am also a teacher and an educator, and I work in medium medium-sized school district in the state of Washington. And I also have spent some time working with parents and students through my work at National PTA. I'd like to welcome all of you here today, and especially Chelsea for joining us today for this wonderful opportunity to have a fireside chat about mental health, our youth, our families, and schools. So, as we know, 50% of mental health conditions manifest by age 14. Trauma-informed practices are well known. However, schools are not quite hitting the mark to ensure students and teachers are informed, supported, and connected to services when necessary, especially when a student is BIPOC and or LGBTQ. This conversation today will explore how policy can support school systems in shifting to be safe, effective learning environments for students, regardless of their background. So Chelsea, why don't you start us off today and talk to us about discussing some of the challenges faced by students and educators during this pandemic, especially Black, Indigenous, and people of color, BIPOC, and lesbian, gay, transgender, and queer and questioning, or LGBTQ, youth, and our adults.
Thanks, Laura, for that question. The first things that I think come to mind, I hope are kind of obvious for our audience. I think we've continued to see really horrific violence against marginalized people splashed across front pages and into talking points. So we're seeing that youth of color are multiple times more likely to die from COVID than their white counterparts. We're seeing that young people of color are more likely to be grieving the death of a loved one in this pandemic, right? The burden of death is not equitably distributed, if that's the word we want to use. Our young people of color, our queer young people, are more likely to have been separated from their parents, from their caregivers, by incarceration, by detention, by families sort of making choices to have to deliberately isolate if they're related to essential work. And I really want to thank some queer educators, AFT members, who have helped me understand that their queer students are very often delaying some critical milestones, like they're not coming out and they're not expressing their gender identity because they're really fearing basic safety in their current home and school arrangements. So I think, the first part of that question is obvious challenges, or again, hopefully obvious challenges. And then I want to borrow from the brilliance of Phyllis Kamara-Jones, who I think has a fantastic analysis of these trends. She specifically has outlined how some people are more exposed and less protected from COVID specifically, but I think her analysis carries over to other public health issues, including mental health. So she talks about overexposure for folks who are in jobs that have been deemed essential. And we are absolutely seeing how schools are public health institutions, and therefore educators are essential workers, right? We have CDC guidance that says schools should be the first to open, for example. We often see that educators are minimally compensated for their labor, and this is just one of the ways that underfunding emerges in schools. So that's some of the overexposure. We're also seeing about overexposure to violence of all kinds, and Jones really credits segregation in housing and education and incarceration and detention for this overexposure and reduced protection to pathogens. So we see that our systematically targeted educators and youth are saturated with media imagery and narratives of death and brutality and expendable lives for people who are assumed to be like them. We are seeing politicians and pundits constantly question whether disparate outcomes are the result of racism. It's an open-ended question. Does a system of oppression matter here? And I think even that line of questioning implies that there might be some inherent deficit in the targeted community that's an alternate or valid root cause of disparity, and that's a dehumanizing frame. So we see this, for example, in vaccine hesitancy instead of narratives around vaccine access, right? When I went to go get COVID tested, I had to have a card. And that means we planned for certain people to have access. It wasn't about my hesitancy or anyone else's. It was about the way that we planned. I think finally, in terms of overexposure, I noticed that educators in particular are routinely admonished to care for yourself, right? Get more water, get more yoga, get more rest. and we're not remaking the systems that allow them to make those choices or fully acknowledging the ways that their jobs are designed to be harmful. That self-care framework suggests that educators are at higher risk because they're not performing the right health behaviors, and it's ignoring institutional design as a social determinant.
Thank you, Chelsea, for those wonderful thoughts about like where we are right now and what's contributing to the discomfort and the inequity and some of the challenges that we face today in our schools. So if I can take off of that and stretch this just a little bit further, can you share with me any evidence of any school leadership interest in meeting students' mental health related needs, both comprehensively, like including social supports, as well as the academic supports, of course? But as schools start to return to in-person operations, where can we find that school leadership interest and the evidence of it, especially for our BIPOC and our LGBTQ youth? Where can you share any of that with us as we listen to what is going to be a really, really important question in the future?
Absolutely, Laura. So first I want to note that at the AFT, some of the folks that people traditionally think of as school leaders, superintendents, school boards, principals are not typically part of the AFT's audience, and they're certainly not members. However, we hear about them all the time from union leaders and from frontline educators who I certainly think of as school leaders in their own right. And no matter which of those folks, I think those stakeholders that we're hearing from, we absolutely know that schools are interested in addressing and meeting young people's mental health needs in schools. Schools are the nation's de facto pediatric mental health institution, and that was true before the pandemic. Schools are committed to fulfilling that role. We know that most children who receive mental health services get them at school. And I know that educators will be the first to tell you that they want their young people to have access to more and access to better. And so I see a focus, at least in messaging. I'm not sure that we're at a point where I can speak to programming yet. Folks are still figuring out how to use their recovery dollars. They're still sort of navigating the many different federal and state packages that have come through and how they can leverage those. But I think we're hearing about intentions right now to really make sure that social emotional learning programs are available, that young people are getting back to their relationships, both with educators and with their peers. I don't know that I see that there's a focus in these on our systemically targeted students. I think the assumption is correct that when we have strong positive relationships in schools, that is an effective protective factor for all children. And I wish there were a little bit more attention to the ways that culturally responsive and tailored programming can be essential and impactful for some of our most vulnerable.
So great. So speaking of that culturally responsible teaching practices and how we as educators and as leaders in our school district and in our schools, and also the support staff that we have, whether it's counselors or interventionists or behavioral health clinics that are integrated or woven into schools. Can you talk to us about any ways that you have seen that schools and school districts are really beginning to address the educator and the student needs, so both of their needs, as they begin to reopen or return to normal, as we like to say? Can you think of any of those examples? Or if not, what key suggestions do you think we should be pushing to policymakers? Like right now through this summer, because like you said, that money is starting to come in, those plans are beginning to be unpacked from some legislation federally and in many states, so that we can actually facilitate a better return to school within our schools through policies and maybe supports and programs.
Absolutely. I'm hearing some really big ideas, and I think that's really heartening, right? We've seen a colossal shift in the country, and I think likewise we have to shift our institutions. We have to shift our imagination, and I do see that. I hear in particular really strong desires to strengthen the staffing of our specialized instructional support personnel, or our SIS, right? So that's our school nurses, our social workers, our counselors, our psychologists, and I think there's a new energy around supporting students through transitions, around making stronger connections with families, around focusing some efforts over the summer. I am not sure that all of those big ideas have fully taken into account sort of what teachers might do or paraprofessionals might do, or sort of all the roles and responsibilities and the staffing implications, but I do see some big ideas, and I hope that we can see some fantastic programming. Pivoting a little bit to your question on recommendations, I think there are two ways that I want to challenge policymakers. So the first is on some very specific, like, try it right now, please don't do it. So the first, the three that I'll put in that bucket are to address and assess the workload of our specialized instructional support personnel. So we very often see in legislation that we have student provider ratios. This does not tell me about workload. We see that folks sometimes are investigating caseload. This doesn't tell me about workload, right? We need to be really looking at how many hours are necessary and reasonable to fully serve any given child's needs by all of those different professionals, as well as restructuring workloads so that our SISP can actually share their robust skill sets with all children. In a lot of places, their workloads are designed to just serve kiddos with acute needs, just serve kiddos with special education plans. They have the training, I hear from them directly, they have the appetite to serve every single kiddo. And that means we need to really think differently about their job descriptions and the ways that we structure their time. The second, and intimately related to that first, we need more SISP. So we need more pipelines. There are not enough workers currently to fill all of these categories. And I think in different places, there are lots of specific levers that might help get closer to the number of workers that we need in some of these categories. So policymakers, that includes reviewing credentials, right? What level of education is necessary to work in a school? And can we change that so that it's reducing unnecessary barriers? This is not a race to zero training. This is really being thoughtful about how much training is necessary to thoughtfully serve children. Another potentially helpful policy lever to pull there is really looking at policy that trusts providers' judgment and not subjecting their decisions about supporting students to further review by physicians, for example. And the third one is really reimbursing people who are earning credits towards a higher level credential while they work under a current qualification. So I'm thinking in particular about school nurses. In many, many places, school nurses under the law are considered highly qualified when they have at least 4 years of an RN, right? They've trained and they have a specialized public health credential. I think school nurses should be supported in reaching that credential. And I think if we have folks who have maybe 2 years experience and are currently licensed professional nurses or LPNs, if they're willing to do the work to get that additional credential, I don't think we should block them from sharing the skills that they have right now with young people. I think we should figure out how to get them on that pathway. And, you know, if they want to work in schools, to welcome them with open arms. The third item that I'll put in that bucket is to really coalesce health, education, and Medicaid agencies in your state to examine reimbursements to schools for student health service delivery. I want to shout out the many, many organizations and states that are doing some of this work already, that are moving from a free care policy towards a paid care policy. And I think there's a lot more work to be done. So if any of what I said sounds new to you, please dig deeper and consider doing some of that work in your state. Any of those policy agendas, I want to then sort of add an additional lens on top of. They need to celebrate providers with diverse identities, people with the skill sets to examine and challenge the default oppressive settings of our society. These are folks who can achieve different and often better outcomes. We see this with teachers, for example. Hiring teachers of color improves outcomes for all kiddos. I think the same is true for nurses of color, for school social workers of color, right? Our pipelines need to take that into consideration. I think these policy agendas have to layer an abolitionist politic and principle directly on top. So as we're creating these systems, we're eliminating surveillance, we're taking out control and coercion as tactics for being effective with young people and addressing their wellness. And third, they need to be trauma-informed and restorative. So in addition to building righteous relationships, we need to be making sure that our systems and our individuals within those systems have the skill sets to restore relationships after a harm.
Thank you, Chelsea. You threw out so many great ideas there, and I was writing them down, and it was making my mind spin because I know that we want to tackle all of those, and we want to take all of those to our policymakers, whether it's at the school district or at the state level or at the federal level, because the urgency, I think, is right now. You know, you closed with trauma-informed practices, restorative practices that will help holistically make us all whole, but reminding ourselves that there are those students and people in our community that are really hurting right now for a variety of reasons, because they have layers on top of layers on top of layers that institutionally haven't been met. And then I heard you talk about reimbursement for healthcare delivery, and I implied in that was both from a medical sense, right? And also from a behavioral health or a mental health sense. And so as you're thinking of those things, if you, Chelsea, were to take one today, let's bifurcate this. First to the state level in the state you're at, and then carry it to the federal level. What would that be? And it may not be the same individual thing, but could you share with us, if you had one to take to your state, what would that be? One ask, compelling ask, and then to the federal level. Can you share your thoughts on that?
That's a great challenge question. I think each state should answer this for themselves, right? And have their own. So where I am might not be the best answer for where you are. In my state, right this moment, of the three that I said, I would love to see a CISP pipeline that really supported individuals at all different education levels to enter and become highly qualified school-based providers. For the federal government, I would love to see a streamlining of Medicaid reimbursements to schools in ways that are not state by state, in ways that are not patchwork. That is a huge ask for the federal government and sort of flies in the face of how Medicaid is designed. I say that I'm asking, I'm suggesting, I'm recommending, knowing that it would not be easy to pull off.
Well, sometimes those not easy to pull off things are the aspirations that set out the pathway, that while we're trying to move there, then we can take care of those other needs. I know you're on the East Coast, I'm on the West Coast. And so I would say, from my perspective, you've probably hit on the two that could maybe transform what we do in schools today. I think you've picked two that are really transformative. That pipeline and that highly qualified credential, to have that only be when you have it, and not to take in the experience and the journey that we're going through, I think is really important, especially for the support staff that we have in our schools. It's not just the teachers. We need to be creative for teachers, but we need to be creative for nurses, counselors, health professionals that need to come into our communities. And so I thank you for sharing those. And I think that you have given us some big aspirations or goals that will help all of us reflect within our state and at the federal level ways that we can really transform what our students and what our teachers will see as we start another school year. Some of us are still finishing up, and some of us are really right now knee deep into getting ready for the next school year. So I thank you for that. So as we wrap this up, I have one more question, and we might take off to another one, but one more question, and it's just a general question for you. Would you like to share any other thoughts that you see a huge ask for either ourselves or for our policy makers? I know you have covered a lot. Is there any lingering thought or challenge you would like to put in front of us as we listen today to some of your thoughts on how we can transform for our LGBT and BIPOC youth, but also for our school systems where we are serving so many kids with needs right now.
I think there are maybe two more things that I've implied and I want to make more explicit. So one, I think that placing marginalized and systemically targeted people at the center of our planning, at the center of our imagining, at the center of our policy dreams is the way that we shift our messaging, is the way that we shift our priorities, is the way that we shift our assumptions. I appreciate Mental Health America really celebrating that Black and Indigenous people in particular have been systemically targeted since before the inception of the United States, and that our queer folks are disproportionately and systemically targeted. I also want to highlight that folks with disability, people in communities that have migrated recently to this country are targeted in their own unique ways. And sometimes folks are facing sort of multiple layers or intersections, as I'm sure some of us have heard, of those different systems and targets at the same time. And being really thoughtful about that, I think, demands new thinking and careful thinking. The other thing I want to notice often happens in health spaces is a tension between prioritizing programs because they can have an economic return on investment. So we'll say things like, for every dollar invested in school nursing will eventually yield $3 worth of benefits. And I think that this oversimplifies what children deserve. Children don't deserve access to school nursing because it will eventually save money. Children deserve access to school nursing because it allows them to live lives of dignity. And if there are economic benefits, I don't think that's a bad thing at all. I don't think it's bad to notice or to analyze it. I don't want us to center or start there.
Thank you for those thoughts. The return on investment, ROI, right? That always seems to be kind of a linchpin because you have to show evidence, right? And I think your talk about the human experience and the human dignity, we did that years ago when we had free or reduced price lunches or breakfasts for students, right? And it wasn't because of the dollar return on investment, it's because every child, right, deserves to come to school and not have a hungry belly, right? And so we do those things and then we carry them on to summer programs and throughout the year. And on spring breaks or winter breaks, I'm in a poverty district. We make sure that we take care of those things, not because there's funding attached to it, but because it's the right thing to do, right? And because we need our kids, they're our future, right? And so those of us in education, those of us around schools, those of us serving our children do it out of that passion. I see that passion in you, and thank you for sharing your thoughts today. You have given us a lot to think about. You are really just a wealth of knowledge, and I thank you for being here with us on behalf of Mental Health America and everyone who's at our Policy Institute. Thank you for your time today. It's been wonderful hearing from you.
Thank you, Laura. Thank you to Mental Health America, and thanks to all of our audience.
Great day.
Well, that is a very clear message from Chelsea to take to Congress, the administration, and states about meeting needs throughout the school community and how to do so. It's time for a second break, but this one will keep you where you are and ask you to practice a tool that is currently being used in schools to build resiliency in young people. One of this week's annual conference themes, From Resiliency to Recovery, and by the way, virtual attendance at our conference is free, will be demonstrated by Laura Bakash, a co-founder of Inner Explorer, and she has the next 14 minutes to share. Laura is joining us live from South Florida, and following Laura's discussion and practice, mindfulness practice, you will hear our third and final panel of the day, Financing Services in Schools, moderated by MHA's own Mary Giliberti. Welcome to Policy Institute, Laura.
Thank you so much, Karen. And I'm so grateful to Mental Health America for inviting me to join in this Policy Institute today. As Karen said, I'm one of the co-founders of Inner Explorer. We're a nonprofit organization, and we provide mindfulness-based SEL, or social emotional learning, in pre-K through high school classrooms and centers. And it's really considered a universal tier 1 prevention tool. And I'll describe a little bit about it. But in general, it's a 5 to 10 minute a day audio guided practice. There's a series that takes educators through the year, and educators and students listen together in the classroom every day. We have it built into the curriculum in a number of districts already, and those numbers are growing every day. And the key is that mindfulness reduces stress and improves cognition, which is really, really relevant for education. So in the next few minutes together, what I'd like to do is lead you through an actual practice so that you have a minute to experience it. I will also share a little bit about the neuroscientific evidence and talk a little bit about what mindfulness does to the brain and what stress does to the brain, and how those things really matter to understand and hopefully embed mindfulness. And then lastly, we'll have a gratitude practice that we'll join together in, one from our program. So with that, I will invite you now, to all the listeners, to please feel free to close your eyes or look downward and simply begin with a few slow and deep breaths at your own pace. And I'll sort of practice along with you. So as you breathe in through the nose, noticing the air as it flows in and out. As you breathe out, same thing, noticing the air, noticing any movement that you feel in your body. Potentially your abdomen or your chest may shift as each inhalation and each exhalation occurs. Just beginning to settle for just a few moments together. Breathing, maybe aware of sounds that you might hear in the room, maybe even the sounds of your breathing. If attending to your breath is uncomfortable, maybe just sensing what it feels like to be sitting right now. Noticing the seat that you're resting on, if it's comfortable or maybe uncomfortable. Potentially shifting in your seat if you need to feel comfortable. Just breathing and noticing. Aware of thoughts that may be coming and going in the mind. On average, we have about 50,000 thoughts a day, so there's a lot. Just letting them come and go without grasping on or trying to push them away, just allowing them to pass. And then as we wrap up this mini practice, taking another deep breath in and out, and then opening your eyes when you're ready. So that was mindfulness, simply paying attention to what's happening moment to moment. And there's a lot of hype about mindfulness right now. A lot of people are talking about it. A lot of schools are already trying to embed it into what they do in the classrooms. And the key is that mindfulness reduces stress, particularly chronic stress, and it improves cognition or thinking. And that really matters in education. So what I'd like to do is show you from a neuroscientific standpoint, a very simple hand model of the brain. So as you can see, I'm holding up my fist. So in my simple hand model, there are 3 parts to the brain. There's the brain stem, which is depicted by my wrist, and that's at the back of my head, and it connects my spine to my brain. And the brain stem is responsible for all of the automatic things that the brain does, like digestion, perspiration, breathing when you're not thinking about it, heart beat, and so on. These are important things for our lives to stay alive, and they live here in the brain stem. The second part, depicted by my thumb, is called the limbic system. It's also known as the fight, flight, or freeze system, and everybody's familiar with that. this part of the brain triggers when there's a threat, and it's really there to keep us safe and free from harm. The challenge is that our limbic systems very often are triggered way more than they need to be. There's something called chronic stress or toxic stress that a lot of children are living with, and that just means that the limbic system is aroused on a very regular basis. But here's the challenge. The third part of our brain model is the cortex, or the cortical structure. The very front here, right behind my forehead, is the prefrontal cortex. Most educators know what that is because most of our learning cortex. So in this part of the brain, that is where executive functioning lives. It's known as the executive center of the brain. So planning, decision-making, long-term memory, all of those things live here. So here's the challenge. When we're stressed and the limbic system is triggered, the prefrontal cortex goes offline. So we say to children, it's like you're flipping your lid. Most everybody on this call has probably had that experience where you've done or said something that you really regret because you weren't thinking, you were reacting. So if you imagine that we have a lot of children, as you've heard, have an enormous amount of stress in their lives, and their limbic system is triggered on a pretty regular basis, which means their thinking brain is not online for a large part of the day. And that is implicated in a number of different mental health disorders, physical health disorders, and certainly poor performance in school. So the brain on stress is very challenged. And what makes things worse is that as the brain is in a chronic stress environment, the brain starts to beef up the limbic system and prune the thinking part of the brain, which is not a good pathway. That leads to dropouts and even worse performance in school and so on. So we want to try to limit or attenuate that, and that's where mindfulness comes in. So mindfulness literally is a countermeasure to the three things I just described. It downregulates the limbic system so that it's less likely to trigger, especially on things that it doesn't need to trigger on. Somebody says something mean to you, you don't need to flip your lid. You can attenuate that. So with practice and regular practice, the brain attenuates stress in the limbic system. It also upregulates or activates the prefrontal cortex. So activity in the smart part of the brain is greater, is more robust. So again, for education, that really, really matters. And the third thing, when we flip our lids, because we're still going to have things that trigger us, even if we're practicing mindfulness all the time, but when we do flip our lids, mindfulness is proven to speed up the time that it takes to get the thinking brain reactivated. That's a measure of time, and that from a biological standpoint is what resiliency is. So resiliency is the time that it takes from when you're triggered to when you're back online. So mindfulness influences all three of those things. So it's critically, critically important that we embed this, and many schools, as I mentioned, are. So what I would like to do now is invite you to join a gratitude practice that is part of our program that we embed in the country. So I will play that now.
What's up, world? Man, I really hope y'all having a good day. Check this out. As we close our eyes, we're just going to have ourselves a little mini practice. You probably know research indicates that practicing gratitude, that is, practicing being thankful, can extend how long you actually live. Which means you're going to live longer if you show a lot more gratitude. That's right, being grateful makes you healthier. So let's go. Let's get straight into it. Breathing in, breathing out. And again, breathing in, breathing out. Tune to the breath. And placing your attention on what you're thankful for. Maybe small things like watching a bird fly by or sunset. Just being aware if there's something right now that you feel grateful for. Perhaps a teacher who gave you a compliment. Perhaps a family member that whenever you're around them, you feel really good. You may even feel grateful just to be alive. I know I do. As you breathe in, breathe out. Staying connected with the good things in your life. And now, opening your eyes. Great job, y'all.
Beautiful. So that was an example of one of the practices that kids do in their classrooms every day in about 6,000 schools across the country. And I think the key message for the listeners is that we consider this approach to be very much an upstream prevention. So this helps children who have diagnosed disorders like anxiety and depression. It helps children that don't. And hopefully it helps children avoid the development of some of those disorders by helping them with, improving their cognitive development and, as I mentioned, reducing their stress. So we liken this to teeth brushing. So if you've brushed your teeth today, you likely did it as a way to prevent dental health problems or prevent cavities. And we think of daily mindfulness practice in a similar way. So a little bit every single day helps to prevent mental health disorders from developing. And certainly, as I said, it will help those that have developed be lessened. So with that, I will turn it back over to Karen and the team. Thank you so much.
Welcome, everyone, to our session on financing mental health services. As I like to say, no money, no mission. So we're going to be talking about how we finance all of the policies that we've been talking about throughout this Policy Institute. And we have with us today an amazing panel, and I'm so excited to introduce to you these experts who will be talking about issues like Medicaid, telehealth, other grant funding that's coming down to states near you. So our first panelist is Alexandra Mays. She is the Senior National Program Director for Healthy Schools Campaign. And Healthy Schools Campaign is an organization that helps students learn and thrive. She is an expert on Medicaid, which, as we know, is a major funding source for youth mental health. And we're delighted to have her join us today. Our second panelist is Mei-Hua Kwong, who is the Executive Director of the Center for Connected Policy. That center is an incredible resource on all telehealth policies. I use it all the time to find out what's going on in different states and the federal government. And we're just delighted to have May join us as an expert in telehealth. And finally, our last panelist is Phyllis Jordan. She is the editorial director at Future Ed, which is a think tank at Georgetown University dedicated to education policy. And Phyllis has written and edited so much over decades on education policy and has been focusing on resources that have come down during COVID for states and local communities. So we're thrilled to have our panelists join us today to talk about how do we finance all of these things that we've said are important for students to have to really thrive, to do well with their mental health. How do we have enough resources to do it in new and innovative ways like telehealth? How do we make sure that the money follows the policy that we want to see? So I'm going to start us off by talking to Alex about Medicaid, because it is this major funding source that we want to have applied to mental health services for students. So Alex, how can states, what kind of policies can make sure that states can make the best use of Medicaid dollars?
Sure. Thank you so much, Mary. So as you shared, we know Medicaid is a really key funding source for school mental health services. And that happens through a number of different mechanisms because there are a number of different models for delivering mental health services within schools. So Medicaid plays a key role in terms of funding what we call our school-based services, which are services that are delivered by district employed providers such as school psychologists, school counselors, school nurses. But then we also have Medicaid pay. Medicaid also pays for services that are delivered by community providers who are partnering with schools to deliver those services. So that might be happening through community mental health centers, through partnerships with hospitals and other clinics. And then there's also a lot of examples where school districts might be directly billing managed care organizations and having managed care organizations pay through their Medicaid funding for those services. So there's a lot of different models, and with that comes a lot of different policy opportunities for states to really strengthen the role that Medicaid can be playing in supporting the delivery of school mental health services. But one of the key things that we really have been lifting up that states can do to maximize this as a funding source is created through a policy change that happened in 2014, which allows states to enable school districts to bill for any Medicaid eligible service delivered to any Medicaid enrolled student. So when I talked about those school-based services before, historically, the way that program has been structured is that Medicaid will just pay for services that are written into students' individualized education program. So those are more of your speech therapy, occupational therapy, physical therapy services. And we rarely see mental health services written into those individualized education programs. But because of this 2014 policy change, states now have the option to allow school districts to seek Medicaid reimbursement for any Medicaid eligible service. And that just presents a tremendous opportunity for states to really maximize Medicaid as a funding stream to support these services. We've seen 13 states leverage this opportunity and move forward with it. And the data we have from those states is really exciting. We've seen, just as an example, Michigan is a state that expanded in the fall of 2019, and their estimates are that just for billing Medicaid for services delivered by school psychologists alone, that they would generate $14 million in additional federal Medicaid revenue to the state. So it is a change that doesn't cost the state anything and brings in those additional dollars from the feds to support this work. So we're talking about significant dollars to support those much needed school mental health services. So that's something we really feel like is a critical opportunity that states can do to maximize Medicaid as a funding stream for school mental health services.
Yeah, if only 13 have done it, there's a lot of advocates out there in other states where it has not happened yet. So you talked about the federal policy in 2014 that opened this up as an option for states. But federally, what other policies should federal policymakers be looking at to allow folks to make better use of the Medicaid program to fund school-based services?
Sure. So there's a number of changes, but one very kind of small, wonky one that we feel like would have a huge impact is that the guidance from Centers for Medicare and Medicaid Services around school-based Medicaid was last updated in 2003. So needless to say, Medicaid and the healthcare system in general has changed in nearly 20 years. And there's a lot of questions from states and school districts about how to implement this program in a way that won't expose them to risk of audit, that answers the questions they have about really how to leverage this program effectively to support the delivery of health services. And so that 2014 change was huge because it really just recognized schools as another site of delivery for the health services, which is fantastic. But we really would love to have that guidance, that updated guidance in place to support states and school districts in leveraging that. So I think it's a tremendous opportunity, for advocates to call on CMS to move forward with this. There have been letters to Congress kind of asking for push on CMS to do it as well. But I think in general, just clearer, updated guidance from CMS is really what is needed to strengthen this program right now.
Thank you. And you talked about Medicaid, and I'm going to move us over to talking a little bit about telehealth, because with the innovations that we've seen over the last year with COVID, there's just been this explosion in telehealth. And schools have been using a lot of the providers that you talked about, Alex, that are getting billed are coming to students over telehealth now. So May, could you talk to us a little bit about what states could do to really better support and finance telehealth in schools, both at the state level, and then maybe you could talk a little bit like Alex did about the federal side, specifically with respect to telehealth, because it's been such a big part of what's happened in the last year. And many, we want to see that expanded access continued.
Thank you, Mary. It definitely has been much more expansive here during COVID-19. I think some people have estimated the policies for telehealth have probably advanced maybe about a decade from where they were to what we saw in the past year. I'm going to spend most of the time talking about Medicaid, mainly because those are probably the policies that have the most direct impact of like what we're talking about, which is providing mental health services in a school setting. But I don't want to discount the telehealth policies on the federal level as well. That is primarily around what happens within Medicare. But that does influence, I believe, what Medicaid programs might do. They do look to CMS and see, like, what are you doing in Medicare? Maybe we mirror some of those policies, or they take that as a cue of how much flexibility they have. Technically, Medicaid programs have quite a bit of flexibility in how they decide their telehealth policies for the particular state. And before the pandemic, there were some states that took advantage of that and had very progressive policies, others who were a little bit more conservative, and then others who were very conservative. So going into the pandemic, you really did have this patchwork quilt of telehealth policies where you could not put two states next to each other and said, like, oh, they look alike. Where telehealth policy was concerned in their Medicaid programs, they were all different. Now, there are typically 4 elements of telehealth policy that touch upon certain things. And that's usually around like what services are covered, what modality you're using, like if you're using live video, or if you're using a store and forward or asynchronous option, or remote patient monitoring, and then the type of provider providing the services, and then the location of the patient. In the situation we're talking about now, probably the most important factors to consider is probably the provider providing the services, the location of the patient, and the services covered. Good news is mental health services are usually the most commonly covered telehealth delivered services. Like you had practically every jurisdiction in their Medicaid program reimbursing for some mental health services. It's the most popular one. It's the easiest one for policymakers to grasp because, when you go in and you talk about telehealth, they're like, you can't touch the patient. Said, well, mental health services, you probably shouldn't be touching the patient in that case. So that's like something for them easy to grasp onto, and why you see it used so prevalently when you're talking about telehealth and like what telehealth policies are out there. Where it gets trickier, though, is the location of the patient. And prior to the pandemic, you had actually quite a few Medicaid programs limiting where the patient is located when a telehealth interaction takes place. Now, there were some states that had fairly robust policies allowing it in a school-based setting. Texas, Georgia, are just, 2 of the larger states that have like a pretty good, robust policy on telehealth and school-based services. The other problem with that is not every Medicaid program was very clear about their policies. So they may have some very vague comment about like it can take place in an appropriate setting, what does that mean? And they may mean the school setting, but they weren't clear on it. So you had provider hesitation or patient hesitation of like maybe starting a telehealth program because they absolutely weren't sure. Come COVID-19, that gets blown out of the water, everything gets expanded, not necessarily the school-based setting during COVID-19, simply because a lot of schools shut down, but there were wide sweeping policies about like, you can have it in different type of settings. They were primarily focused on the home, but there were some states that expanded like where the option was in like receiving telehealth services. The question now that everybody is struggling with is, what do we keep around? And that is a discussion that's happening both on the federal and on the state levels. You've got multiple states who have made some policy changes and enacted them and said we're keeping these things around permanently, and others who are still mulling that over, and definitely it's still being mulled over on the federal level as well.
So on the federal level, you were mentioning that Medicare often influences Medicaid. What are some of the policy issues that you think at the federal level will impact what the states think about?
Well, part of the problem with the federal level is that a lot of their policy limitations are in federal statute. So it is literally an act of Congress is needed in order to like change that. So CMS has their hands kind of tied on that. Really the only sort of leeway they have is sort of the services that they can cover. What is sort of the most hotly debated question right now is really around, and we haven't talked about it, the modality that's being used, and that's the audio only modality that's being used right now in a lot of jurisdictions. Prior to COVID-19, when you were talking about telehealth, you have a lot of places, a lot of people, when you asked about, well, what about telephone, audio only? They said that's not part of telehealth. But because of the pandemic and recognition that not everybody could utilize telehealth because for whatever reason, lack of access to technology, lack of broadband, audio only may have been the only option for them to receive healthcare services. So that's really the biggest sort of one of the biggest discussions around now. And also the other sort of elements, the one I touched upon, is like the location of the patient. Can you have them in these alternative settings, that aren't like sort of your more typical healthcare settings? Like Alex had mentioned, they had finally got recognition in 2014 that these school-based programs were, a health setting where you can receive healthcare services. That's still a little bit not in the telehealth policy there, where you have a lot of jurisdictions that don't recognize a school-based setting. They stick to the typical usual suspects of like a doctor's office, a clinic, a hospital. So that's like another area where on the federal level, if there's changes made there, it could influence what happens in the Medicaid program, but that's complicated by the fact that you need Congress to actually enact something to get that change made. Personally, I kind of think they may take the route of doing a temporary measure of once the public health emergency is over, we may keep X, Y, and Z around for like another year or two to gather data and examine whether this might be a good policy to implement on a permanent basis. And I would not be surprised if several states do the same thing. There's actually a bill that was issued. There was a bill in Connecticut where they are doing that like 2 years, like send it out the temporary measures for 2 years just to study it.
Okay. Well, and as you mentioned, there's the issue with audio only of equipment, right? What equipment do people have? And that kind of leads me into my next questions for Phyllis about, the funds that have come down from COVID, because those could be used by school districts, by others for a variety of uses. So Phyllis, can you talk to us a little bit about the grant funding that is available to states and to local school districts, and sort of what recommendations, how is mental health covered or not covered in those, and how should policymakers and others be thinking about those funds?
Sure. Thanks, Mary. Well, as you probably know, Congress has done 3 packages of COVID relief dollars, and all of them have significant money for K-12 schools. The CARES Act, which passed last March, had $13 billion. It's called SRSA. No one remembers this one, but it passed in December as part of the budget, and that has $54 billion for K-12 schools. And the American Rescue Plan, which just passed, has $126 million, which $123 billion.
Billion with a B.
Billion, B for billion, sorry. $123 billion for public K-12 schools. All of this money has very broad uses. And in each case, they label some allowable uses. Mental health services for students is an allowable use in each case. Also, they stress social emotional issues for development of students, which has a mental health component too. The money flows from Congress to the states, and then from the states to the school districts. The states can keep 10% to spend, the local school districts get the rest. And they have a lot of control. I've had people ask me, oh, how can I apply for this money? You can't apply for the money unless your school district has some sort of grant program. Essentially, the states and the local school districts have the money and are now deciding how to use it. The money that went out last year, the CARES Act money, much of that's been used, but the SRSA money just arrived like mid-spring, and the American Rescue Plan money is just getting to school districts now. In terms of how to use it for mental health, the Department of Education just released new guidance today that lays out some ideas. I mean, they have a website, they have handbooks about ideas, but specifically I looked for what do they say for mental health. And they, they sort of, there's the two focuses. There's mental health, the kids who need therapy, who need counseling, who have depressed, anxious, or have some sort of behavioral issues. And they recommend hiring counselors. They recommend doing evaluations. They recommend a trauma-informed approach for helping not only students, but their parents and the teachers. They recommend professional development for teachers on mental health conditions. And then on the sort of social emotional side, which is sort of a lower tier of support, but it's, making the school feel safe and welcoming and a calm school climate. They, recommend everything, again, hiring more personnel, having culturally responsive curriculum and programs, trauma-informed approaches, even music and sports programs. You can use the money for music and sports programs if you feel like this is going to create a better climate at your school and a better experience for the students.
How should we think about sustainability? Because a lot of this money came down, and it's short-term money, right? So right. How should policymakers at the state level or even local levels be thinking about these resources?
That's a really good question, because as you said, the money doesn't last forever. Each of the three packages extends out for a couple of years. The last of the money has to be obligated, not spent, but committed to something by September 2024. So you don't want to go out and hire too many people because you're not going to have the money to keep them on your staff after 2024. You might hire some people and maybe make a plan to figure out how to start paying them through Medicaid reimbursement. But you also could do community partnerships, bring in, especially I think the first year back, you're going to have issues figuring out which are the kids who need counseling for anxiety and depression and which of the kids who just need a better climate and a chance to get used to school again. You're going to need some professionals to help you figure that out. Telehealth is a really great investment. A lot of communities would like to do this. A lot of schools would like to do this. They don't have the equipment. They don't have the training for how to do it. So why not spend this money you have now for that equipment and for the training? In terms of training, there's also an issue with school discipline, whether the kids have mental health issues that require counseling or they're just out of sorts from a year sitting at home. There are going to be behavioral outbursts. There's going to be issues that come up. And the worst thing we can do is just send those kids, suspend the kids and send them home. We need teachers and counselors need to deal with those issues, need to help kids, and teachers need to be trained in how to approach discipline in a more restorative and culturally responsive way.
So we've covered a lot of ground, and I think a lot of people thinking about these issues are, trying to figure out where to prioritize, what are the most important policies. So I think I'll ask each of you, if you had to prioritize, what is the most important policy change that you think could take place to really help move forward school-based mental health services? And I'll come back and start with you, Alex. What do you think would be the most important thing to focus on?
I would just echo what I said earlier. I really think, expanding state school Medicaid programs. I think in general, for states to really look at who the providers are who are delivering those mental health services in schools, what are the services that they're delivering, and aligning that and making sure that those are Medicaid eligible providers and Medicaid eligible services within their states. We often see a lot of disconnect between what is happening on the education side and what Medicaid might pay for or recognize. And it's more from a lack of understanding, I think, of really the work that is happening in schools and the critical role that schools are playing in terms of providing school-based mental health care. So in general, I think that opportunity to expand and just strengthen and align the education and Medicaid programs around this work.
That makes sense, Alex, to really maximize those dollars that you have. So May, what do you think is the most important policy for folks to focus on?
The telehealth perspective is what I touched upon when I spoke earlier, is that they need to ensure the Medicaid programs need to ensure they allow the school sites to be an eligible site where children can receive services and have that covered by the Medicaid program. That'll go a long way to like sustaining like that particular telehealth program in a school setting. But I think, Phyllis also touched upon the other aspects to it that aren't directly related to reimbursement policies. There is a bit of ramp up for these school programs that they need to do. They need to have the equipment, they need to have the training for telehealth to ensure they're able to do that. So I think it would be wise on the state's part to like also invest some funding in that to like have that allowable, and also have that be able to happen in a school setting, because there's probably quite a few schools that don't have that right now. So they will need that equipment. They will need that bit of extra training there, whether it's for your school nurse or your counselor, some sort of idea of like, it's not just turning on like the laptop or the computer or something. It's recognizing, as Phyllis was talking about, recognizing certain issues, recognizing when to use telehealth or when to stop it and say like, this is probably not the best case to use telehealth. We may need to like have like an in-person visit with a provider and the student as opposed to doing this over video. So also investing some funding on that end to help programs get started too.
And Phyllis, what do you think is the priority policy for the future? What would you choose as the most important thing to move forward with?
Well, I think we need a paradigm shift for the need for school psychologists in the schools or access for kids to school psychologists. We have something like one school psychologist for every 1,500 students and one school counselor for every 430 students. And the school counselors are often tied up with college counseling, as they should be. But we need to realize that we need to provide more access to mental health services for kids at school. This affects academics, it affects attendance, and it affects discipline. There's so many ways that we need this. So the federal government, the state governments, and the local school boards need to invest more money in this priority. And one opportunity for advocates to make that clear is that right now, states and local school boards are developing spending plans for COVID relief dollars. The states have to submit them to the education department, and the local governments have to submit them to the states, and they have to have meaningful consultation with many community stakeholders. So this is an opportunity to talk to your school board members, talk to your state government, and let them know this is a priority.
Wonderful. So people need to get active in those plans. And we want to see this paradigm shift so students can get their services right where they are, which would be so much easier and would provide much more equitable access for all students. This is great. This has been a wonderful panel. Thank you so much to all of our panelists. Thank you to those listening. And this concludes our panel on financing school mental health services.
Hi, everyone. That was a wonderful, wonderful panel that we had. Thank you, Mary, May, Alex, and Phyllis. We really appreciate all of the content that you shared. And we want to turn things over to a young person that's also been involved in financing advocacy for mental health, Melanie Zhou. We are really excited to have Melanie, who is a freshman or just completing her freshman year at Stanford University. She is in her high school in Colorado, was involved in doubling the budget for counselors and mental health professionals. And we just are really excited to have Melanie here today with us. Melanie, please take it away and let us know about your advocacy and why you were empowered.
Thank you so much for the introduction, Karen. Hi, everyone. My name is Melanie, and I am a freshman at Stanford and also the co-founder of Oasis, which is a mental health nonprofit that builds physical and mental health rooms in public high schools. If you see my background, this is actually one of our Oasis rooms in Colorado. So while I was in high school, I helped my school district double the amount of money and allocation for school-based mental health professionals. While it's also in high school, I was able to serve on a one-time committee allocating $10 million for school-based mental health services. You may be wondering how I was able to achieve these different things. Well, the first thing is I came into a time when my school district had recently passed a mill levy override in order to fund more educational services within my school district. Something my peers and I realized, though, was not a lot of students were being represented in how they were going to allocate the money. And what I mean by that is in terms of a district receiving allocation for more money to use for services or school-based mental health, oftentimes students are not invited to sit at the table to recommend how those services and that money should be allocated. In that school year, when we had just passed the mill levy override, my school had experienced a suicide. And it was one of my peers in my classes, and it was something that really shook my community. And I realized that throughout my school district, this was something that was very normalized and very common to have a student commit suicide and then not have a lot of students do anything about it or have a lot of advocacy thereafter. And I realized something had to change. And we realized because of this time that we were in, where our district was funding new educational services, we had to stand up and advocate for mental health as one of the biggest priorities for the financing to go to. So my peers and I, who founded Oasis with me, we showed up to almost every board meeting and Board of Education meeting to discuss and advocate for mental health as a bigger priority within the funding of how they would distribute this mill levy override. We advocated and we presented in front of the Board of Education for 3 months straight. We talked about how school-based mental health professionals would be a really strong need within our community because a lot of students who are suicidal or who face normal daily anxiety or depression really don't get to see their school-based counselors because of a shortage in funding that keeps them within a school. So after sharing these points, we advocated to our superintendent about getting students actually part of an oversight committee to make sure that our voices are represented within the allocation of funding. So while I might not know about financing, particularly like how the schools and how a district receives financing, what I can advocate for is giving students an opportunity to share their voice and represent what they want at the table. It's so important to get kids, especially in regards to mental health, to express what works, what doesn't work, and what they really need. And within my school district, what we really needed was more school-based mental health professionals, and we were able to double the amount of money allocated to them for that. So I really recognize and advocate for any student who is feeling like they don't have a lot of power to show up to board meetings and to speak during the open period, to kind of give their voice when asked and really advocate for a seat at the table. It's so important for kids to share and participate in these important conversations that will affect them on a daily basis. And for any policymaker, any legislator, any educator that may be listening, make sure you invite different voices that represent students because they are the ones who are going to be feeling the tangible effects of the financing that you choose to allocate. Thank you so much.
Thank you so much, Melanie. We're just incredibly proud of the young people who participated in today's program because of the motivation that they had from within to make changes and take action in their community. I'm just thrilled by the community engagement and ability to lead on something so important, yet something that has been difficult to discuss over the last few decades. To conclude the program, I have the pleasure of introducing Annie Reed, who serves as National Director of Thriving Schools at Kaiser Permanente, where she leads strategic development, oversight, and evaluation of large-scale school-based programs aimed at addressing teacher, staff, and student physical and mental health. She has worked at the intersection of public health and public education for 15 years.
Hi, I'm Annie Reed, National Director of Thriving Schools at Kaiser Permanente. As we've learned, as we've participated in this convening, we know that we have a mental health crisis among our youth that began well before COVID and has only been worsened by the pandemic. COVID-19 has had a disparate impact on the mental health of children and adolescents, as many are missing the opportunities that school offers for play, socialization, and other in-person interactions to learn and process the world around them. I know because I have a 6-year-old who's really struggled with this. We need to address those who are struggling, but equally important, we have to prevent and intervene early in mental health conditions. Prevention, early identification, and treatment of mental health issues should occur where and when young people are most likely to present concerns, like in schools, which is what brings us all here together. We know how much the pandemic has laid bare how much children and families really depend on schools, not just as sites for quality education, but also as community anchors for social interaction, emotional support, healthcare, including mental health, and nutritious meals. That's why school systems really have to return in the fall with the support they need, including the tools, the resources, and the know-how to address the health of students, including the social emotional needs, as well as the staff that support them. That's what's going to allow us to return to a new normal and to an environment where everyone can be successful. This is our moment to really identify and help elevate the importance of health and mental health in schools. You have heard from youth leaders throughout the program that have brought about incredible change in their own communities related to mental health. And it's important that we continue to put youth front and center as we develop policies and programs aimed at supporting them. While some students have been empowered to take action even despite adversity, all students should be involved in the process of creating mentally healthy schools and communities. We often think about the wellness of students, but we also must support the policies and programs that promote the mental health and well-being of the whole school community. That's why at Kaiser Permanente, we've made sure to highlight the needs of all teachers and staff. Supporting educators and staff in the school community ensures not only that we have caring and emotionally available adults to support students, but also that the educators and staff in a school building are satisfied with their jobs, are able to support each other, and be able to be present both at work and at home. Finally, we will not have strong school-based mental health services for all youth and staff without adequate resources. As you heard at the end of the program, while we've had a windfall of short-term financing through federal relief, really we have to focus on more sustainable methodologies for ensuring that we are always able to take care of the mental health needs of our school communities through things like financing via Medicaid, continued support through telehealth, and increased funding for school mental health personnel. Additionally, providing services on-site in a school is a priority issue for ensuring that mental health is available to everyone, especially for children of color who are disproportionately represented in those students who only get their mental health services at school. At the beginning of our time together, Dr. Don Mordecai mentioned several Kaiser Permanente resources to support schools and districts in prioritizing the social and emotional well-being of their communities. I also just want to make sure to mention our Planning for the Next Normal at School playbook that we developed at Kaiser Permanente in collaboration with 30+ national and local organizations that are leading school health. The playbook offers actionable plays for every key dimension of health, including mental and behavioral health, physical health like physical activity, recess, and healthy food, social health like housing and economic opportunity, and with strong considerations of family engagement, racial equity, and financing. So I encourage you to take a look at that if you haven't already by visiting our Thriving Schools website. I'll just say that this is really a pivotal time in our nation and one that we can leverage to shift our education systems, to transform so that health is at the center of education with a special focus on mental health for all students and educators. It's been such a pleasure to be here with you for the duration of this convening. A huge thanks and congratulations to Mental Health America for convening us all to tackle this hugely important and timely topic. And thanks to each of you for taking the time to listen to our program today. We at Kaiser Permanente and Mental Health America look forward to working with all of you to ensure that members of school communities experience mental health and well-being.